My name is Casey and I'm a fourth-year student pharmacist at Stanford University. Today I just wanted to talk a little about morphine and fentanyl in the neonate population. Neonate pain is often underrecognized and undertreated. Peripheral nerve receptors are plentiful by 22 weeks gestational age, with infants consciously aware of pain as early as 29 weeks gestational age. One thing with morphine and fentanyl that we do have to look at in the neonate population is weighing the risk versus the benefits of either the adverse effects from not treating the pain or the adverse effects from the opioids. Also, another clinical pearl that I did want to mention is that opioid infusion should be weaned slowly prior to discontinuing them. The first medication that I want to talk about is fentanyl. Fentanyl causes rapid analgesia and is a synthetic mu-opioid receptor agent. It is 50 to 100 times more potent than morphine. It has less GI motility effect than morphine, which we will talk about when we talk about morphine's adverse effects. Fentanyl also decreases pulmonary vascular resistance in persistent pulmonary hypertension neonates or in those recovering from cardiac surgery. Fentanyl also causes less histamine release, which leads to less cardiovascular effects. This is good in patients who are hypovolemic, in patients who have hemodynamic instabilities, as well as patients who have congenital heart disease. The risk of fentanyl include withdrawal intolerance, and this is usually with continuous infusions that are greater than or equal to 5 days. Also, IV push fentanyl should be infused slowly over 5 to 10 minutes to prevent chest wall rigidity. The half-life of fentanyl is 8.4 hours, and you can see here the different dosing for both IV and continuous infusions for analgesia and sedation of fentanyl. The adverse effects include bradycardia, chest wall rigidity that you treat with naloxone, as well as opioid tolerance. Neonates with prolonged vent dependence may require prolonged exposure to opioids, and this can lead to tachyphylaxis or drug tolerance. So this is a rapid loss of the drug effects and the responsiveness of the drug with prolonged use, so usually greater than 5 days. Tachyphylaxis does increase the neonate's dosing requirement, but it does not improve the efficacy of this medication. In this situation, fentanyl may be swapped to morphine due to the increased risk of tachyphylaxis, and this is called the opioid rotation. And this rotation is utilized to maximize the benefit of the opioid we are using while we are still mitigating the risk of adverse effects and dosage increases. Morphine is used for neonate abstinence syndrome as well as analgesia in ventilated neonates. It is metabolized in the liver into M3G and M6G. It has a slower onset of analgesia than fentanyl, with the mean onset of action being 5 minutes and a peak effect at 15 minutes. The half-life is similar to fentanyl at 9 hours, and you can see here again the IV and continuous IV dosing for morphine. Adverse effects include hypotension, especially in patients with a gestational age of less than 26 weeks or who have pre-existing hypotension. Other adverse effects include prolonged assisted ventilation, as well as increased time to reach full feeds due to GI motility effects. Some things to monitor with morphine include respiratory rate, oxygen saturation, blood pressure, heart rate, and urine and stool outputs, as well as pain relief via a pain scale assessment. And below are my references. Thank you.